In this video, we will discuss cold nodule of the thyroid gland and its evaluation. So what's a nodule? A nodule is a palpable swelling or lump of more than 1 centimeter in thyroid gland. There is an increased detection of thyroid nodule. What's the cause of that? It's because of ultrasound. On palpation, only 5% of people have thyroid nodules, but on ultrasound examination, 25% have thyroid nodule. A nodule may be non-neoplastic, benign, or a malignant tumor. A non-neoplastic nodule may be hyperplastic, filled with colloid, or an inflammatory nodule. A benign nodule may be cystic and a follicular adenoma. About 1/3 of nodules are thyroid cysts, and how they are diagnosed? The cyst is diagnosed by ultrasound. Malignant nodules may be a thyroid carcinoma, lymphoma, or a metastatic tumor. So what's the ratio of the benign and malignant nodule? It's about 10:1. What are the differences between benign and malignant nodule on examination? The differences between benign and malignant nodule on examination are as follows. Consistency, soft versus hard. Size, small versus large. Mobility versus fixation. Slow versus fast growth. And well circumscribed versus ill-defined. The ratio of the nodule, male is to female, is 1:4. Majority of the thyroid nodules are benign and do not need treatment. Most benign nodules are asymptomatic, slow growing, non-toxic, need simple follow-up without treatment. A solitary nodule is a non-functioning nodule. Most patients with cold nodules have normal thyroid function. So what are the investigation done in case of a solitary or a suspicious cold nodule? In a cold nodule or a solitary cold nodule, the TSH is normal. That means it is a non-functioning. So what's the next step in case of a cold nodule? FNA biopsy. And what do we get on FNA biopsy? More than 70% of the cases are benign, 20% are non-diagnostic, and 10% are malignant follicular thyroid carcinoma, the most common. In case of a benign, which are more than 70%, what's next step? Monitored by ultrasound. Suspicious malignant follicular adenoma or follicular thyroid carcinoma. Treatment, surgery is done. Cytology does not differentiate between a benign and a malignant form. It's non-diagnostic in 20% of cases. So what next in non-diagnostic cases? If evidence is insufficient but it enlarges rapidly, then ultrasound guided FNA biopsy is done. Otherwise, a second biopsy is done in 2 to 5 years to confirm benign status of the nodule. Cold and malignant nodule take less radioactive iodine than normal thyroid tissue. 10 to 15% of the cold nodule becomes malignant, whereas only 5% of the hot nodule becomes malignant. What are the advantages of ultrasound? Ultrasound detects non-palpable nodules. It detects nodules which are more than 3 millimeters in size, differentiates solids and cystic nodules, localizes the nodule accurately for accuracy of the sample, also diagnoses suspicious nodule with microcalcification. Ultrasound identifies adjacent lymphadenopathy. And in case of multiple nodules, ultrasound has a selection of nodules and is useful in detection of recurrent carcinoma. What are the sonographic evidences or characteristics suggestive of malignancy on ultrasound? They are microcalcification, increased vascularity, and hypoechogenicity in the nodule.